Good morning. Is this coming through okay? Hello? Oh, there we go. Good morning. What's great. Well, it's great. We're glad to see you all this morning. Just so you know, there was just an announcement overhead that this is being recorded. This is being zoomed out, and then they're recording the Zoom as well, just so you're aware of that. My name is Dr. Ben Fredrick, and I'm Director of Global Health here on campus. I am a graduate of the medical school back in 2000. Anyone? Nope. Okay. Well, one of these days. And it's a pleasure to welcome you back to campus. I've been here since 2003, so I've seen the changes all along the way, but hopefully, if this is your first time back for quite some time, you've seen some ongoing new developments in the construction, and then, of course, with the curriculum, a lot of changes going on in really exciting ways. If you graduated before 2010, we didn't really have any kind of global health program here. We had students going abroad on electives called international electives or medical missions trips. But from 2009 onward, I developed a global health scholars program, and I'm here today with a number of second-year global health scholars. Next slide, please. And we want to share with you a little bit about the program because it's quite an exciting program. We started with 6 students in one country, and over time, we are now averaging about 30 students in the program and 7 countries. We take about a quarter of the medical school class into the program. This year, I'm thinking we may be receiving applications for up to a third of the entire first-year class wanting to join the program. The program is a 4-year program, and students have 2 trips abroad. One occurs at the end of their first year. So these students just went abroad in June and July for a month-long rotation with their colleagues to one of our 7 international sites. Then they will go back again in their 4th year in February of their final semester, and they'll have another month-long experience. The first year experience is really more community-based. It's learning about the culture and the healthcare system and the unique aspects of what are called social determinants that connect and social influences on health. That then prepares them a bit more to provide clinical care under supervision in their 4th year return trip. So it's really exciting, and we keep these students together as a cohort through their full 4 years of the curriculum. Next. These are the sites that we're offering this year. It includes a domestic opportunity. So we've been doing a lot in the global or international realm for the past 12 years or so. We're starting to expand and do domestic, which I think is really exciting. Likely includes Indian Health Services in the future, and then perhaps even border medicine and maybe street medicine. You can see the different sites up here that we currently have. Each site is run by a different faculty member. So all of our faculty are volunteer, and then we have scholarships that help to support these students. We're able currently to provide travel scholarships for 4th years. If they make it through the program, and the vast majority do, then we cover their 4th year travel completely. We cover a chunk of their 1st year travel, but we'll need to raise more scholarship funding to support these students if we keep seeing the numbers increase as we expect. So each site is different, so students will apply to the program, and then we have an application process with interviews and a selection. We try to figure out who's the best fit for which site. So you're going to hear a little bit about each of these sites today from our students, and they're the real stars of this show, so I'm going to turn it over to them. So again, thank you for coming out this morning, and we look forward to questions that you might have, and also look forward very much to hearing from Dr. Birx later after our presentation. We will hold question and answer or question and response until after Dr. Birx's presentation. So thank you.
Yeah, thank you, Dr. Fredrick. Good morning, everybody. My name is Katie. I'm one of the second-year students that traveled abroad this summer. I was a part of the Australia cohort. So I spent some time in Melbourne and then a couple weeks afterwards in rural Australia in a town called Mildura, which is about a 7.5-hour drive north of the city. Not quite the outback, but what they like to call the bush. So that's where I was. I think I can speak for all of us when I say that we made some really memorable experiences, some lifelong memories this summer. And I know that we're all looking forward to continuing this program and get to go back to our sites. I'll share with you all, and before I introduce everybody else, that's me with a koala bear up in the top corner. That's my favorite non-medical memory that I had this summer. I went to a wildlife park while I was road tripping through South Australia, got to hang out with some koala bears and feed some kangaroos. So I will introduce everybody else and pass the mic down.
All right. Hi, guys. My name is Sonakshi. This summer, I was lucky to go to Nepal. And so that bottom left-hand picture is actually a Tibetan medicine hospital in the foothills of the Himalayas, where we got to learn from both kind of master and apprentice in that program there, and really learn about the traditional forms of medicine that Nepal still relies very heavily upon. So it was a very unique and very memorable experience for me.
Hi, everyone. My name is Sarahrose, and I went to Macha, Zambia this summer. Our picture is with Emma as well. It's the bottom middle picture, and that is Emma and I performing a DNA extraction and later PCR of the malaria blood samples that we collected out in the field.
Hello, everyone. My name is Samuel. I was lucky enough to go to Vietnam. So that top left picture there is with a couple of peers of mine who went with me, and also a local doctor called Ni. She was someone who toured or showed us around her hospital, her community hospital, and we got on really well. She spoke incredible English, and she was kind enough to kind of show us around the city of Dalot and all the great street food places, and we tried some incredible food along the way, and yeah, absolutely incredible.
Good morning, everyone. My name is Nitya, and I was one of 8 students who went to Ghana this summer. Our picture is the one on the bottom right. So that's our whole cohort who went to Ghana. There's 8 of us, and we went on a little hike, and then we went to this place called the Kukum Canopy Walk. So it's a series of suspension bridges. It was really fun. A lot of us got to conquer a fear of heights, but it was a great experience, and I really enjoyed it.
Hi, everyone. My name is Emma, and I was with Sarahrose in Macha, Zambia. So I'll pass it back to Katie now.
Okay, all right, let's get this closer. So as you all can imagine, there was a lot of work and preparation that went into our trips and gearing up and flying out this summer. So last year we met as a cohort with Dr. Fredrick. We did a lot of research about our sites, talked a lot about uncertainty from a cultural lens. We read books about different kinds and classifications of cultures globally, and just a lot of global healthcare issues that are going on. So by the time summer came around, we tried to go to our sites with a global mindset and take on our local sites in that way. Like Dr. Fredrick said, this is a longitudinal experience. So we will get to return to our sites in 4th year. So that'll be exciting to return to a familiar place after we've had more clinical experience, kind of see a familiar place with a fresh perspective on things. Additionally, I really want to emphasize that this is a true like cultural local immersion that we had. Yes, we got to do the fun touristy things, but I will never forget even just walking to the grocery store, seeing kangaroo tenderloins at the butcher counter, or going with the Australian medical students to the farmers markets in town, grabbing brunch, or as they call it, brekkie, grabbing drinks with them, or even just going to their sim sessions and classes and doing rounding with them. So a true day in the life experience of an Aussie medical student, I'll say. But also got to have some cool traditional cultural experiences as well. As you guys can kind of see it in the bottom right-hand corner there, that's called a smoking ceremony, which is a traditional Aboriginal ceremony that's meant to, it's kind of a physical, spiritual, mental cleansing that you do. They burn and kind of smoke out some eucalyptus leaves and other medicinal herbs that they traditionally use in their culture. And for me, the longitudinal experience at our site is very personal. I've kept in touch with so many of the students that I met there, and actually a couple of them are coming here to Penn State in January. So we'll have to show them a good time here in Hershey. Additionally, so we continue this program while we are back here in Hershey between our cultural immersion experiences. So what goes on in those 2 years before we go back? So upon return, we did a lot of co-sharing with one another in our small cohort, having really deep, vulnerable, and reflective conversations. We talked about the positives, the negatives, and all the craziness in between of everything that we observed and experienced while abroad. Really challenging a lot of our views and learning to, kind of have reservations on your judgment and taking in the community and the experience around you and trying to learn it through their perspective. So that was really cool getting to hear secondhand from my fellow classmates and getting to teach one another about those cultural experiences. And this is a really unique aspect of our cohort, is that we get to continue meeting through our Keenly groups and clerkship. So that's kind of a small humanities group, humanities curriculum-based group that will be touching base throughout our clinical clerkships this upcoming year. So our group will be just global health students. So that's really awesome that we get to have familiar faces and, you know, continue those deep and vulnerable conversations, get to the real meat of our observations here in the US healthcare system, but being able to pull from our global perspectives and our experiences and relating to people who have experienced similar things to us. Additionally, we continue to build the global health community. We will be joining some of the first-year students as they come in. So I will get to talk to the next Australia cohort, help them prepare for their trip, help them, you know, do their research and give them some travel advice, some tips and tricks, and a little budgeting as well. But that's really nice that we get to continue building a strong community of global health students over the years, and still getting to connect with, you know, all 4 years across the medical students of people who are a part of this community. And lastly, as you all can imagine, traveling with people, other people, kind of brought us really close and bonding in some unique ways, but also good opportunity to bond with our faculty that we wouldn't otherwise have bonded with in the College of Medicine. So that's been really fun, getting to have sort of these mentors, these people that we can connect with outside of our day-to-day life of the College of Medicine. It's not just your small group facilitator or someone lecturing. It's someone that you've had a lot of shared experiences with, and someone that you can connect with on a personal level as well. I know some of my colleagues have had great experiences with their site leads, and I'm grateful for Dr. Henriquez, Eileen, and Bill, for those of you who know them. They've been so helpful and so kind. So it's really nice getting to have that community build of the students, the alumni, and the faculty that are all interested in global health, and that we can continue to have interesting and deep conversations about these topics that we're all interested in implementing into our clinical careers in the future. So that's been amazing that we can have those connections early on in our career.
Absolutely. And just as an example for that, Dr. Tim Craig, who was my site lead, he went to Vietnam with us, an incredible individual. And he's been so kind enough to kind of have myself and my peers who went to Vietnam as well around to his house for dinner, for coffee on numerous occasions. So to kind of just building those relationships, even outside of the professional setting, is really nice to kind of talk to someone who's been through your shoes without having to kind of always put on the facade of professionalism. Kind of, you know, you can lay back on the couch and kind of just talk freely, which is absolutely, it's a nice experience. So of course, this whole global health trip is important, and it's a wonderful experience, but it's also important that we keep it in mind, how is it going to, you know, help us in regards to our success for our future careers. And Dr. Fredrick and the rest of the kind of global health team was able to provide us with a blue book that allowed us to kind of go through these prompted and guided kind of reflections and just questions that and things to be, like, kind of keep an eye out for while we're over there during our cultural immersions, and that's obviously a great start. But more than that, nowhere else in our curriculum, I don't think we experience the kind of ability to kind of navigate this uncertainty and kind of the newness of a completely brand new culture. And as much as you kind of study the culture and the politics and everything beforehand before you go, it's just obviously never the same as when you're there. And navigating this uncertainty is something obviously we've been told many times from our kind of mentors how important this is during our career, and something kind of gives us the ability to kind of taste that earlier on. And finally, I'll just say, I think the United States has a kind of negative public expectation that when foreigners kind of travel to the United States and become a part of our healthcare system, we expect them to kind of adopt our way of medicine and As a result of that, kind of going abroad allows us to just kind of see the other side of things and see how others kind of get to the same results of great healthcare and great patient outcomes, whether that's through preventative medicine, things that perhaps we should focus on a little more over here in the United States. It just gives us another opportunity to kind of see the other side of medicine.
And this is just a video that we wanted to show of Sarahrose and Emma getting to have some fun with some local kids in Zambia. But it's moments like these that are so memorable and give us so many opportunities to connect with the local people and reflect on. So with that said, we'll let Sarahrose share one of her reflections from the Blue Book, so you guys can kind of see how we go through that reflection process.
Yeah, so just to circle back to what Samuel just mentioned about our reflection process, it's a what, so what, and now what journaling process. Dr. Fredrick created sort of a scavenger hunt for us to really identify and then reflect on all the emotions that we're feeling while we're abroad. So we thought it might be nice to give you a little glimpse into our journaling process. So I did bring my Blue Book here. It's gone through a lot of love while studying abroad, as you can see. But I'm just going to share a journal entry with you about my time in Macha, Zambia. So for the what, the experience, this was actually a journal entry from our very first day shadowing in the male and female wards in the Macha Mission Hospital. And this is when I really first started to notice how different the conditions were in Macha to the United States. The lack of privacy, the sanitation was minimal and even non-existent. There was no modesty, and even the systems errors due to their no technology that they were recording any of their data in. So for my so what, I immediately realized that my beliefs, assumptions, and values were challenged about how I thought care should be delivered in the US. And I had to quickly shift that mindset, especially given the limited resources, physicians, medications, you name it, in that hospital. So it really forced me to take a step back, challenge my assumptions, especially given the context of the new environment, and ask myself, maybe they are doing the best they can with the resources they have. As for the now what part of my journal entry, I said that I would use these emotions, turn them into actions that I can do to make a difference, no matter how big or small. When I see an elderly lady shivering in the TB ward in front of open windows, I'll get her a blanket. When I see a patient covered in his own excrement laying in bed, I'll help clean him up. When I see a patient's pain being overlooked, I'll hold their hand or give them a smile to show them that I care. It's moments like this that it's easy to get caught up in the emotions of frustration and anger at what you're seeing, especially as you compare Macha to the US. But it's using these emotions to challenge your assumptions about what you've been taught about patient care. So that was just a little glimpse into all the experiences that we've had while we were abroad. In addition to this, Dr. Fredrick also tasked us with finding out how people with HIV are viewed and treated around the world. So we're really excited to share some of those findings with you right now.
So yeah, like Sarahrose said, we had a great opportunity to have unique firsthand experiences in countries of varying HIV prevalences. So on the next slide, I've placed stars where we were. And we can see that Brazil, Australia, and Vietnam have a similar HIV prevalence to the United States. Ghana, which is in Northern Africa, is a bit intermediate. And Zambia, which is where Sarahrose and I were, had the higher prevalence, though of course the prevalence varies within the country itself. But one thing that we noticed was that there was definitely a lot of unequal access to HIV treatment and stigmatization to varying degrees in different countries, and different perceptions of how HIV positive individuals are perceived in their communities may play a part in the ongoing epidemic of HIV in certain parts of the world. So these are some of our observations based on our firsthand experiences, but we noticed a few trends in the way HIV is perceived globally or at the sites that we visited. And I certainly don't want to make any sweeping generalizations, but some of the trends that we did observe included the following: a stigmatization of individuals with HIV, although this did vary between developed and developing countries.
In the developed countries, it was more associated with the LGBTQ community. But in developing countries, it was more seen in its relation to polygamous relationships and a general sense of uncleanliness. So that was pretty interesting to observe. And at most of our sites, there were issues of limited access to care and sometimes exclusion from care. And certainly there was a fear to seek care in an attempt to expose a diagnosis and to avoid the harsh stigma that still surrounds this disease in many parts of the world. And then all of these can lead to very bad consequences. We know that HIV can lead to AIDS. So it's just unfortunate, some of the things that we observe. But next, one of our activities that we did when we came back was rating our countries on a scale of highly vulnerable to highly protected. And this is a non-scientific approach and just based on our observations, but it helped us to make some comparisons and share our stories with how individuals with HIV are perceived. So in Zambia, Sarahrose and I were able to go to HIV clinics to speak with some of the nurse assistants there, and also sit in on some follow-up visits with HIV patients. And in this country, HIV was spoken of mostly in terms of its spread from male to female partners and within polygamous relationships as well. So there was not much talk of HIV spread amongst men who have sex with men because engaging in same-sex relationships is actually illegal in Zambia. In addition, men who were known to be HIV positive were not responsible for wearing a condom, even if their partners requested. And if a partner did request him to do so, he may just outright refuse to. Overall, there was a lack of education that we noticed, and there were several myths surrounding HIV and how it could be treated. One of the myths was that a man who has HIV could be healed by having intercourse with a virgin. But on the other hand, our classmates' experience in Brazil was completely different. Sao Paulo was essentially a haven for members of the LGBTQ plus community. And our classmates, Sam and John Lee, actually had the opportunity to interview an infectious disease specialist in Sao Paulo. He spoke a lot about how they built a program for HIV patients to receive care. And he said that there was in fact a lot of discrimination at the beginning, but they noticed that this HIV pandemic was something that they needed to take care of and that it wasn't a problem of just a few. So they started to observe this or perceive HIV as more of a public health problem, something like hypertension or diabetes. And now the care for HIV patients is much less stigmatized. And this is especially in Sao Paulo, but it could look different in the more rural areas of Brazil. But these are just some of our observations that we've been able to make. And we ranked the other countries on this scale as well, but it's been really informative to come back and share these experiences and learn from each other.
So now that we've talked a little bit about the stigma and the perception surrounding HIV care all around the world, I'd like to talk a little bit about the innovations and the kind of new ideas to overcome those barriers to access that have kind of sprung up and that we've observed in our experiences. So in Nepal specifically, there was a great deal of stigma that we saw not only amongst the general population, but also amongst the medical community. And we saw patients that had been refused care by their physicians. I got to interview a woman who had an abortion because she wasn't informed by her physician that she could have a child that would not have HIV with proper treatment. And so really stories like these were very common, but we did see kind of, glimpses of hope for the future. And one of those was a new program to train members from high-risk communities to not only educate their community members, but provide tests and direct them to proper resources. So one of these programs actually trains women that are recruited from the line of sex work. and they are educated about HIV and prevention, and they're provided a number of free tests to disseminate amongst the community. And they're also taught to counsel people that test positive to seek care. And so these kinds of low resource interventions are really able to make a big difference, and not only kind of increase access to care, increase testing, but also develop trust and kind of a healing partnership between the general community, especially those belonging to high-risk groups and healthcare professionals. And so these kinds of innovations were really inspiring to me personally, just to kind of see how even in what we perceive as a very low resource setting, they're able to come up with a great deal of very effective interventions.
So while in Ghana, we had the chance to gain a firsthand perspective of the country's health system, how that differs from the US, and how the structure of their system helps impact HIV care and treatment. We were able to interact with some officials from the Ghana Health Service, and we learned that the health system is decentralized in Ghana. Their country is divided into 10 regions, and each region is further subdivided into 4 levels. There's a national level, a regional, a district, and a sub-district. So the sub-district level, since it's much more focused in on a smaller area, it allows for a strong community health emphasis in the country. And we were able to visit a community-based health planning and service compound, or CHPS. That's a picture of us in the middle with the nurses and the staff at the CHPS compound. And these sites often serve as the first point of primary care for many individuals in Ghana and rural communities. They were able to show us some of the innovations and the services that they provide for HIV. So they provide screening, antiretroviral treatment, counseling for HIV positive individuals, and also services for prevention from mother to child. On the right side is one of the tests that they show us. It's a combo CAR test. It tests for both HIV and syphilis. It detects antibodies to this. And these are widely used at these CHPS sites. They have been really vital in decentralizing testing and helping individuals in rural communities gain access to testing, and they get the results in less than 30 minutes, which has truly made a difference at these sites for people to understand the prevalence of HIV and gain treatment much more quickly. So after coming back from our trips, having the time to reflect, all of us being able to discuss what we learned in our observations, we saw that internalized stigma and stigma from others in the community was a common theme that we identified. Unfortunately, this negatively impacts access to care and willingness to receive treatment, despite all the innovations and all the advancements that have been made in the field. But we were able to learn a little bit about some of the steps that have been taken to help mitigate the stigma, and steps that are well suited to each country's culture and each country's environment. While in Ghana, we observed in the hospital that instead of using the term HIV, the providers would use the term ARV, antiretroviral. And this sort of helped protect patients from stigma from others around them in the hospital. Additionally, as I mentioned on the last slide, community health was quite prevalent, quite important in curbing HIV in Ghana, as the CHPS sites that I mentioned and other interventions that take place on a community level.
Okay, well, you have heard so many amazing things about the Global Health Scholars Program, from our experiences to the longitudinal curriculum, to being able to collaborate and co-share with our colleagues, and most importantly, the reflection aspect. So that brings us to our what now? Being able to come back and have these conversations with our colleagues about all of our unique experiences while abroad has really opened our eyes to just how different the ideas, the cultures, the stigmas, the perceptions, and even entire healthcare systems are all the way across the globe. It's also showed us how navigating uncertainties and having an open mind can actually directly translate into the care that we give our patients. Most importantly, it's definitely laid the foundation for us to be the culturally competent, equitable, and patient-centered physicians that we really hope to be. Okay. Again, we cannot emphasize how much of an impact this 4-year curriculum will have on our medical education. So with that being said, we want to give a big shout out to Dr. Fredrick, Tamika, all of our site leads that went abroad with us, and everyone who has donated. We can proudly say that no student has ever not been able to go on their trip due to financial reasons. So thanks to the scholarships and the donations, we've all been able to make our dreams become a reality through this program. And I guess to conclude, we have a little video to sign us off. We're very excited for our return trips in 2025. And this is the beautiful song in Macha, Zambia of one of the choirs singing.
Thank you very much.
Well, good morning, everyone. I am Marissa Hoover, Executive Director of Academic Medicine Development, and it is my distinct pleasure to introduce to you a special distinguished alum from the College of Medicine class of 1980, Dr. Deborah Birx. So I'll tell you a little bit about her and why we have brought her here today as part of her recognition for the Distinguished Alumni Award. Dr. Birx, as I said, got her degree in 1980. She is continued to train in internal medicine and clinical immunology at the Walter Reed Medical Center, and also served in the National Institutes of Health. She's a board certified internal medicine, allergy, immunology, and diagnostic and clinical laboratory immunology. She spent her first career as a United States Army colonel, and then later in some of the most high-profile programs for the Center for Disease Control and Prevention and the Department of State. Most recently, you may recognize her from her role where she served as the White House Coronavirus Response Coordinator, where she made recommendations to the Vice President and the White House using complex data and provided on-the-ground state-specific advice and guidance to our legislators. In 2014, Dr. Birx is part of the work that we have recognized her for. She became an ambassador at large when she assumed the role of the coordinator of the United States government activities to combat HIV and AIDS. And she was a US Special Representative for Global Health Diplomacy. Dr. Birx is a renowned medical expert and leader whose long career is focused on a clinical basis in immunology, infectious disease, pandemic preparedness, vaccine research, and global health. As the US Global AIDS Coordinator, she oversaw $6 billion annual budget for PEPFAR, the President's Emergency Plan for AIDS Relief. This is the largest commitment by any nation to combat a single disease in history, as well as all US government engagement with the Global Fund to fight AIDS, tuberculosis, and malaria. Dr. Birx is an established researcher, publishing over 230 peer-reviewed manuscripts in journals. She has authored nearly a dozen chapters in scientific publications, developed and patented vaccines, as well as having authored her first book, Silent Invasion, just released this April 2022. So it is my pleasure to welcome Dr. Birx to share more about her experiences working with HIV.
Thank you, Marissa. Really appreciate it. And wasn't this terrific? Because people ask me all the time, how do you teach empathy? You don't teach empathy, you learn empathy through humility. And I think this whole experience, Dr. Fredrick, thank you for understanding that unique and different experiences build humility that allows us then to have empathy. And I think sometimes dealing with the COVID response, I'm convinced that as a country, we at times lack empathy. And I think that was really very evident. So I am going to talk mostly about HIV, but try to weave in that really COVID-19 was not an unusual pandemic. We have really faced other pandemics. Everybody always says we haven't seen a pandemic since 1918. I think it's so convenient to forget HIV. But with HIV, you can see there are still misinformation and myths. There are still the concept of therapeutics that are herbal without a scientific justification that are still used around the world and frankly here in the United States. So all pandemics are political. if you remember 1980 and Ronald Reagan and how HIV was approached. All pandemics are political. All pandemics have misinformation, largely driven by fear when people don't understand what's happening to them. And all pandemics were solved in stigma and discrimination. And I think that's what our job is. And it's really great to be here with you all and be back at Penn State. And Marissa, thank you for coordinating all of this, because I was running all around the world when this was happening, and she did all the heavy lifting. What I've learned in all the years of combating pandemics is what usually is missing is implementation. You know, we have a lot of theories, we have a lot of policies, we have a lot of tools, but we stop at that. And then we don't collect the data to see if these things are implemented. So with HIV, what became really important is distilling it down to, and I love the way your journal is, because this is very much like that, although we didn't talk beforehand, is really political will matters because policies matter. And getting those policies that you need in order to decrease the structural barriers to access, to create equity, to decrease stigma. And what drives often policies and political will is data, because it becomes a neutral place of joint understanding, kind of like music. I love data. It speaks to me, much like music speaks to many. But data matters because it allows us to see past our perceptions to the reality on the ground, and allows us to see who needs to be reached and not being reached, and find out why and what we have to do differently. And then it really creates, because of that, is equity. The United States doesn't really understand equity. They think of equity as equal. So when I came into the White House, I was talking to Asper, the head of Asper, and I was like, where is all the PPE? And he said, oh, we sent it all out to the states based on population. I was like, what? You sent our national stockpile of PPE to people based on their population rather than where the virus was? Yes. So in that first run, there were lots of states, in fact, 90% of the states that had PPE that never needed PPE. And I can tell you, it's impossible to get it back. They're not going to give it back to you. Political will is often underestimated of how critical this is. And convincing presidents of African countries that they have to take the LGBT plus community seriously, and we have to have specific programming when it's against their political nature and could result in them losing their presidency, is a very difficult place. But political will allows the translation of policy into action, because otherwise it sits on the shelf. The WHO writes something, but the Minister of Health never executes it. They do. They say, we've developed all these policies, but they tell them quietly not to execute. And so it never gets done. So what does that look like? What does the data show when you have the political will? This is just the difference between HIV prevalence in Russia versus Ukraine. And although they started out, Ukraine, in a much worse situation, when the country developed political will to address their primary epidemic, that was people who inject drugs, and tailor programs to that group, they dramatically decreased the rates of HIV. Russia refused to deal with their people who inject drugs programming, and they would not do anything short of locking individuals up. And they would not do any medical treatments for people who needed substitution therapy. I'm not sure where I'm supposed to point. Okay, great. So Uganda, and I'm going to tell this story really quickly about why data matters. So if you look at this blue line, that's new infections. And we had already been in the field for about 7 years. In Uganda alone, we had spent about $2 billion of taxpayer dollars, and yet we weren't dropping new infections. And I really looked at this. I was at CDC at the time leading that program. I brought it to the State Department and I said, this is a crisis for me because we're investing a lot of money. And although we're decreasing the death rates, which is in the light blue line, we're not decreasing the rate of new infections. So we did a complete top to bottom program review. Now, the blue bars are the budgets. So we didn't dramatically change the budget, but we used data to show what parts of the program were working, what parts were not working, and we took the money from the programs that weren't working and we put it in the programs that were working. Okay, that should tell you right now I was not very popular because you're taking money away. I mean, everything is good, but we couldn't afford good. We had to move to great to impact it. So that orange line is the rate of people being diagnosed and put on life-saving ART. And before the program review, we were moving slowly along. And then after the program review, with all of us moving in the same directions, no additional resources, we dramatically changed the ability for people to receive life-saving treatment. The same way with PMTCT. It's really important to know sometimes the WHO is financially driven for its policies. So you remember they were very slow in recommending lifelong ART for everybody, very slow. And you wouldn't believe it was really only 5 or 6 years ago where we finally had that global change. But we really pushed for all women to be given treatment for life because the children were getting infected during late breastfeeding. So they were giving mothers 6 weeks, 8 weeks, 3 months of ART, taking them off. And then the children would get infected from late breastfeeding. So we started a program again in Uganda with the additional resources to ensure all mothers were on lifelong treatment. You can see how few mothers were on lifelong treatment. You can see that purple bar dramatically increases again in a flat budget. But we also wanted to increase prevention because we had this issue with high rates of new infection. Now, if you're on lifelong treatment and you're virally suppressed, less likely to transmit the virus. But we also knew voluntary medical male circumcision was highly effective. We didn't have the money to do it. So again, in a flat budget, rearranging the dollars, we were able to start this voluntary medical male circumcision program. And you can see how many circumcisions were done over those ensuing 3 years. So then when I took over the program in 2014, we were already 11 years now into a program. Now, if you know politics in Washington, people get bored and they get bored with programs. And so the lifetime of a program is limited. So you really have to make tremendous progress quickly in a program to really ensure that you can have the impact that you really desired. So that orange line is our budget, and it's flat, and it had been flat since 2008. So we were confronted with a situation of high need, not enough people on treatment, not enough people getting prevention resources, flat budget. How are we going to deal with this? So we learned in Uganda and we took that to the entire PEPFAR program, over 50 countries. And we did these deep dives, bringing together the community. And I think that's what you heard from the team here, bringing the community to the table with the Ministry of Health. So we don't plan any aspect of our program without us being there, the ministry being there, but the community being there in equal numbers, giving voice to their issues and their needs. And you can see the yellow line is, the yellow bars are the number of circumcisions and the green are currently on treatment. And so in 2014, we have 7 million people on treatment. And today, just 8 years later, we have 20 million people on treatment, again, in a flat budget. I keep saying flat budget because if you hear when people talk about what's wrong in this country with public health, they keep saying we need more money. But it's not always about more money, it's how that money is used. And like they showed you, this is prevalence and size of the country, how many people have HIV in that country. And you can see this is a global map. You can't see the rest of the world. So most of HIV is in sub-Saharan Africa, South Africa, Nigeria, certainly East Africa, Zimbabwe, Zambia, very high rates. So when you do change management in government, it's a little bit difficult because you can't fire anybody. So we really tried to set the program on 3 guiding principles of accountability, transparency, for impact. And so we now have all of our data since 2014 down to the site level. It's on the pepfar.gov website. You can see all of it. You can see all 20 million people who are on treatment. And we get data quarterly for the program. Now, what else did we discover when we did these deep data dives? And this is the other important aspect of all of this. This is HIV prevalence in Kenya at ANC clinics. That's the panel on this side. So mothers are coming in pregnant, found to be HIV positive, and through a sentinel surveillance that they had done several years earlier. But you can see that there's whole areas, and this gets to the equal thing. There are whole areas of the country where there's almost no HIV. Really no HIV. But our money, US taxpayer dollars, were distributed in a more equal way based on clinic and population rather than a need-based way. And you can see the majority of infections are in the Kisumu region right outside of Lake Victoria. And indeed, when we looked at all 47,026 sites that are PMTCT sites in Kenya, almost 2,000 of the sites had never had an HIV positive woman. Now, this is 11 years into the program, where every day people were just looking at the data, collecting the data, collecting the data, collecting the data, not acting on the data. Now, I see you're horrified by that, but that's what we're doing today with COVID. We're collecting the data, we're collecting the data, we're collecting the data, we're not acting on the data. And so 90% of the patients were in 28% of the sites. So this is a problem because then you have to shift resources. Now, I know this map is hard to see, but I wanted to show this map because the area of political opposition in Kenya is in the Kisumu area. These are ANC clinics, number of positive women with HIV. You can't see, there's a whole bunch of squares. Those are clinics that we were funding no HIV positive women. And then you have these really large number of women in the Kisumu area where the separation between the clinics is often 10, 20, 15 kilometers when every other clinic in every other part of the country is within less than a mile. And so our money was being used to expand clinics in areas that agreed with the president and decrease clinic access in those areas that had the highest issue, but were in opposition to the president. The other thing that we did is we hired a group that wasn't us, and we said, go in and do community-based surveys. Not with us, independently, and tell us what's really happening. We know what we have for program data, but what are you seeing with fully powered, on-the-ground, community-based HIV surveys? And we found some surprising data. We found that for both men and women under 25, most of them had not been diagnosed. We also found very good data that 80% with our program reforms, within that first 3 years, we were able to get to about 80% of men and women diagnosed with HIV and on treatment. So this was a great gain. The other thing that we saw is this is the difference between females and males. And if you start to really look at the data, until puberty, the number of males and females under 14, same numbers, basically equal. But starting at 15, young women are now 2, 3, 4, 5 times more likely to be HIV positive than young men. And you say, well, how are they getting infected? They're getting infected from the men that are 25 to 34. And so this was a way that we could really figure out where we have to work. And until we got this data, there hadn't been any programs for prevention of HIV in young women. It was all thought to be too complicated, too difficult, because there were structural issues. And people in medicine do not like to fund structural issues. They like to fund drugs and surgeries, not the structural issues of keeping young women in school and dealing with a community that believes that they should be married at 14 or 15. So putting the young women in the center, we had meetings with young women all through the many countries that we launched this DREAMS, determined, resilient, empowered, AIDS-free, mentored, and safe young women, with that nomenclature because that's how complicated it was to address the issues with young women, working on strengthening the families. So they didn't just send the young boys to school, they sent the young girls to school, and we helped with those school fees. Mobilizing communities for change so that the chiefs in those communities would end or stop or prevent marriage of young girls under 18, which was a very common practice, and then to reduce the number of sexual partners in young women. And so this was a comprehensive, non-medicalized intervention, but really a level of structural interventions. And this is just in the first 3 years of execution, how much we dropped incidents in the counties and provinces where we were working of incidents in young women, ranging from a 60% decline to at the very lowest was an 8% decline. And so these kinds of programs work, but you have to get the data and you have to constantly get the data. So with using granular data in real time, we were able to identify key gaps and then use those key gaps to change our programming in real time. And that is what made all the difference in the program. And that's what allowed us to provide quality and equity. Now we continued to work on that. That was 2014. The data got more and more refined. This is the data from Uganda just 3 years ago. Again, every single person had been counted by age band, and we knew what ages we were missing, what genders we were missing. So we knew precisely how many males and how many females, children we were missing. And this really is the stigma and discrimination piece. Parents are reluctant to have their children diagnosed because then the village knows. They can hide their own ARVs, they can hide their diagnosis, but they're very worried about their children telling people at school that they're positive. And so there's a lot of stigma there. So you can see the lowest group on treatment. Now we give ourselves a red, that was 60%. But some places we had 90% of people on treatment. And so we knew it was achievable, we just had to work at it. So we had very granular pieces. I won't go through all of that in light of time. But once you know who you're missing, you're able to match your testing strategies, you're able to match your treatment strategies, you're able to match to the needs of that community member. And this is how detailed the data is. This is pie charts from every single county in Uganda, showing where are we finding people, how are we finding people. And the only thing to take home from this is the big green wedge in the male side is finding people in TB clinics. That means they're late. You're finding men still very late in disease. We're still finding women, the pink is in the ANC clinic. And with all of that work, it can have a tremendous impact. And going back to the Uganda slide, we were able to drop new infections in parallel to improving people staying alive. So we have data from all of our countries now. I won't go through all of it. I mean, the important thing to see is country after country after country has both decreasing deaths, decreasing new infections. And in many of the countries, Eswatini, 50% of the adults over 18 were HIV positive. So this is making a huge change country by country. And I just wanted you to see the consistency. So you know that, yes, we look at the national level, but we also look granularly at every single county and every single community to make sure we're having the same impact. Some countries we have not had the impact that we wanted to have. This is Mozambique, this is Nigeria. We completely reformed both of those programs 3 years ago. Angola has been very difficult because they have the ability to fund their programs, but they are not taking their HIV program seriously. And they have the highest level of infant and child mortality of any of the countries in Africa. And South Sudan's been in conflict. So just to end with very quickly COVID and why I think those parallels are so important. Every pandemic creates an inflection point. We know that with HIV. All the immunology we learned in HIV then became the immunology that we adapted to cancer therapy. And so it's really quite remarkable. But this at-home testing and telehealth will change the ability for access if we allow it to. And so the other thing is I saw incredible innovations at the hospital level. This hospitals without walls that I saw being implemented all through the South. This incredible database. Now I know Pennsylvania medicine a little bit. Can you imagine University of Pittsburgh, Penn Health, and Penn State Health all working together and having their dashboards visible so that everybody in Pennsylvania got the best care that they could have during COVID? Well, that's what they did in Chicago and the entire Chicago suburbs. And if you think, oh, well, it's just Chicago. Let me tell you, they fight as hard there as they fight here. So they created a dashboard that was updated hourly to show where ECMO was, where ventilators were, and where access was. And they had that available to every ambulance, every EMT, so the decisions could be made on how to transport patients so that they could get the best care. But this pandemic laid bare, and I don't expect you to be able to read this, but laid bare issues that have existed for decades and have gotten worse in this country. And this is where I think Penn State Health can really play a really important issue, because our care in our tribal nations and our care in very often in rural communities has significantly deteriorated. And I'll show you then what that results in. Just to give you my big concerns about the fall. I'm sure you're tracking this, but EVA Shield, which was our really help for people who couldn't get vaccinated, is starting to fail against B4. So this is really critical to know this for your nursing homes and elderly. So that's really an issue. Rebound with Paxlovid means that it wasn't 5 days isn't enough. And that's what sets you up for resistance. And let me make it very clear, if we lose Paxlovid, we don't have anything in the wings. So really working with your medical teams in Pennsylvania, no matter where you're from, and really working to a 10-day Paxlovid in older people will become critical to preserve that drug. And Australia had a normal flu season. Now, this should not be concerning. It wouldn't have been concerning 4 years ago, but it should be very concerning right now. We still have 34,000 people in the hospital every day from COVID. You add on that a normal flu season, and you're up to 70, 80, 90,000 again of people in the hospital with flu or COVID this fall. So the flu season is shown in red. It's all on the Australian Ministry website. The top one is hospitalizations. The bottom one is cases. I know you can't even see this. This is the last 2 years of flu. That's what ours looks like. So they had a 2020 flat season, 2021 flat season, and then a normal 2018, 2019 season early came in June and July rather than July and August. And it's very suggestive that our flu season could look like this. We usually mirror Australia. So what I do know, if all of our COVID surges are predictable, I'm just going to leave you with that concept and show you a little bit of data. The reason the surges are predictable and have these very distinct geographic patterns is because as human behavior in the United States, we have a very predictable geographic pattern. And so when people talk about yearly vaccines, you're not paying attention to the data, because yearly vaccines, of which the duration is less than 6 months, and you have every 6 months an outbreak across the South, just basically says, I don't care about what's happening in the South. Because the South has a southern outbreak in the summer as people move indoors because it gets too hot to be outside. And the Northeast goes inside in the winter. And so we often don't have a really significant summer surge, but the South does. Now, I know you all know this, but herd immunity cannot be obtained or sustained with our current COVID vaccines. And what's unfortunate, I think, is it was very evident in the data from the beginning that that was never going to be possible. Why do I say that? Because natural infection never led to protection against reinfection. And that data was very evident in India and South Africa by December of 2020, when we knew that people were getting reinfected. So we only studied the vaccine to protect against severe disease. Those clinical trials that you have heard about, we never sampled patients that did not have significant symptoms. We were not testing in either the placebo or the vaccine group weekly to see if people got COVID infection. We relied on self-reporting of symptoms consistent with COVID for people to get tested. But we know for people under 30, the majority of people have asymptomatic disease. So we don't know. And the vaccine was never studied or powered those trials to look at infection. They were only powered to look at severe symptomatic disease and hospitalization. I just want to mention this about vaccine development because it worries me to my very soul. Because it was never explained to the American people the difference between vaccines that induce lifelong or prolonged immunity that can lead to herd immunity in the communities, they implied by default that the COVID vaccines could do that. And so now parents are saying, well, what about measles, mumps, and rubella? What about polio? What about these other vaccines? Were they or weren't they protecting my child? And so I know many of you know that if you got measles as a child, you were protected against measles for life. And so childhood vaccines that mimic natural infection of prolonged immunity protect for life. And because we weren't clear to the American people about COVID, when you talk about trust and distrust, this is where it comes from. Nuances in science that we don't explain clearly because we think people can't understand it. And that's why I return to that same comment. You want to build empathy, you want to have conversations with your patients, you have to have humility. And we implied that we knew a lot more about these vaccines, and I won't go through polio and measles and smallpox. I just want you to show you this South Africa slide. Now, there's no one in this audience that could look at this slide and say, oh my golly, there's not reinfection. In fact, reinfection is exactly every 4 to 6 months. So we had a clear roadmap that said natural immunity wanes so much after 3 to 6 months, you have a new outbreak. And that data was clear. That data was clear for years now. And we're finally now telling people, get boosted if you're at risk. And that's what we should have been saying from the beginning, because these vaccines cannot create herd immunity. They're current vaccines. We might be able to make a vaccine better than nature. It's hard to do. That's why we don't really have an effective HIV or malaria vaccine for adults or a TB vaccine. It's really hard when you don't have that natural infection roadmap. There's a lot of data now. I put them in here for those of you who like to look up stuff, but this is how quickly, this is a composite of about 40 or 50 studies. This is how quickly protection against infection wanes with less than 50% protection by 150 days. And this was with the non-Omicron variants. And this is how fast protection against severe disease and hospitalization wanes. And just to remind you, this was from the Washington State Ministry of Health. Vaccines are great, but they're not Superman. And you're not superhuman because you got it. That data where people were talking about it was 100 times more protected than the unvaccinated, or 50 times more protected. It's 3 times. It's 3 times more protected. And so we are having people that are hospitalized that are vaccinated and boosted. Why do I say that? Because if they're tested regularly and get Paxlovid, they won't die. So when we talk about layering protection, vaccine, boosting, masking, testing, Paxlovid. Those are the tools we have, and we can prevent serious disease. This was today. That top line is number of people in the hospital over 70, or daily admissions over 70. Daily admissions of people over 70. Daily admissions of people over 70. This should worry us because it's continuing at an extraordinary high rate. And let me tell you, if you're over 70 and you're hospitalized for a serious infectious disease, it's debilitating. And you don't come out completely the way you went in. This is my last slide. This is annual deaths in Americans. That bright blue are COVID deaths. year by year. So over 375,000 the first year, over 400,000 the second year. I think we're going to get to 275 to 300,000 this year. We're already over 220, and we have the fall coming. This is lung cancer deaths each year, and this is breast cancer deaths each year. So as a country, we take cancer seriously. But as a country, we haven't taken infectious disease seriously at all. And I was actually horrified to find out that in the 20 years I was gone and working on definitive diagnosis for people with fever in Africa, so that you saw the HIV test? That's everywhere. Malaria test, it's everywhere. Before COVID, flu tests were nowhere. We allowed that to happen. We as physicians wrote down that people had flu when we had no idea what they had. And we didn't even question it. In the 21st century, where you can study people's cancer cells down to the nuance of the receptor types and what kind of treatment they need, we were deciding if you had an infectious disease based on your symptoms. Now, we all know, how are you going to tell flu from parainfluenza, from mycoplasma pneumonia, and a child from RSV, from COVID? You can't, but we pretended we could. And this is the humility that we need to bring now, because now we know it. We decided not to diagnose infectious diseases, particularly respiratory infectious diseases, but I'll tell you, GI infectious diseases, we didn't do a great job either. And so the entire CDC and our entire pandemic surveillance system was syndromic. Now, to me, that's the same as someone coming into your office tomorrow and you saying to them, you know what? You have cancer. And they say, what kind of cancer? And you say, cancer. And you say, here is the generic treatment for cancer. Wouldn't we be so behind in sophisticated, individualized treatment for cancer? Well, if you want to have better treatment for flu, for COVID, for parainfluenza, for RSV, you got to diagnose it. And I can tell you, if in private insurance and CMS required definitive laboratory diagnosis for every time you put down an infectious disease code, you'd have cheap assays that were high quality in your offices. But we didn't ask for it, so it was not made. So I'm hoping that if nothing else, two things come out of this. One, we take rural health seriously, because I'm sorry, I promised I was ending, but this is life expectancy. This is life expectancy among Native Americans. It was already 10 years lower than white before COVID. Now it's all the way down to 65. 65. Will this be enough to wake us up to say whatever we're doing through the Indian Health Service is inadequate and it's not working? These are death rates among people by age. Native American, 2%. You're over 65. We have the tools to prevent all of that. And so places like Penn State Hershey are in such an interesting place because they're at that intersection between highly sophisticated medical care and rural communities. And what I tried to explain with HIV, it's about knowing what's keeping the community from access. And maybe you need to go to them. I can tell you, if I had gone to Africa 20 years ago and said, you know what? I put ARVs in the Walgreens down the street, and I put tests in the CVS, and I put PrEP in the CVS, and you just go down there and you get that test and you get your medicine. We would have gone nowhere. No, we got into communities, we used data, we figured out what was missing, we figured out what age groups we weren't reaching, we went into churches. I love the story about we couldn't figure out why men were not coming to the clinics. And so I got a marketing team and I said, please, so they did it for free. Private sector came in and did a lot of research and came back out and said, well, here's the problem. Men don't believe anybody in their relationships except for their mom. So if you get to the mom, you can get to the men. So we went to the moms. I don't understand this about men. I had 2 daughters. But apparently, boys have unique and happy relationships with their mothers, trust their mothers. They don't trust their wives in the same way. Let me tell you, we've asked this question all over the world. They don't trust their children in the same way, but they believe their mom cares about them uniquely for who they are. And so we went into the churches because 90% of women go to church on Sunday. And we said to the moms, we want your sons to thrive. So we're giving you tests for HIV, take them home, get them tested. Here's how they can get treatment quietly without being exposed. And it worked. So I know there are things that can work in rural communities, but if we keep doing this, if we keep politicizing and polarizing COVID, there's a reason death rates are higher in rural counties that voted for Trump, because they don't have access to the same health care. And there hasn't been a primary doctor there forever. There's a dollar store. I was in all of these communities. There is no doctor office. There's a dollar store. And when COVID hits someplace like Louisiana and Our Lady of Mercy Hospital fills up from the people who live in Baton Rouge, where do you think those 8 hospitals in rural northern Louisiana can send their clients? There is no place to send them. And they don't make space for them. They don't say, hey, you know what? I've got some less sick people. I'm going to send my less sick people to your community hospital, and you send me your really sick people. That didn't happen. And so when you see this kind of difference, when you see absolute numbers, of course, they're higher in urban areas, particularly that voted for Biden as an indicator of an urban area. But if you look then by population, you see the red lines are higher. And that just tells you that is a rural area when those lines switch like that. And so we can feel better about this if we want to just make it sound like it isn't our fault that people are dying in rural America. It's who they voted for and the choices that they make. But that's on us as healthcare professionals. That is not on them. And it's on us to fix it. And so I'm really now, I did spend 20 years in Africa and Asia, but I'm completely dedicated to deal with the health issues that I see here, because we created those solutions somewhere else. And that's why this program represents, I think, some of the best things that the medical school is doing, because they will have an experience that they can take back to communities to try things that are different, that work elsewhere. And so this arrogance that we are somehow better and more capable is keeping us from really serving the people that we need to serve, every American. So thank you. I really appreciate your time. It's such a privilege to be here.
Fantastic. Thank you, Dr. Birx. I was taking notes all along the way. Is it now on? Okay, there we go. Okay, so anyway, well, that was a wonderful, fantastic presentation. Thank you for that. We have a few minutes for a question and answer, or question and response. I'm not sure we have the answers. What kind of questions might you have for any of the panelists? Yes.
You know, what we learned with HIV with combination therapy. I know that molnupiravir did not like outperform Paxlovid, but they work through 2 different, very completely different mechanisms, and molnupiravir seems to have a very unique mechanism. And I was wondering if there's been thought to combination therapy as more effective therapy.
Thank you. So I'm out of government now. I knew that little stint was going to be the end of my federal career. It came to a screeching halt, but that's okay. You know, we all move on. And it was a thrill to have a talk without people, first question being Clorox. So this is what worries me the most. Really, Paxlovid is almost a single place of action. One's a facilitator for that single point of action. You're absolutely right. And so I talked to Dr. Fauci at least weekly saying we need combination or we're going to lose one of these drugs. I mean, the virus, it's an RNA virus, single strand, it's random, it's making mistakes every day. It's not trying to find a better virus, but it does by default because it's making millions of odd mutations every time it divides. And every time it replicates. So yes, we should now, early on, they screened all their repertoires, but I don't know if they screened their repertoires with combination drugs. And so, drugs that only work 20 or 30% can end up being 75 and 80% in combination. And you're absolutely right. That's what needs to be done because I believe Paxlovid could hold, but when you get rebound like that, that's just a setup. I mean, we know that from bacteria. That's your way you get escape. So it really worries me that we're setting ourselves up for a Paxlovid failure. But you're right. You're absolutely correct.
Was there another question over here and then over here?
Yep. Yeah, so thanks to all of you on the panel and Dr. Birx. So medical education has been purposefully increasing the breadth of the curriculum as we saw today. So we're not just telling med students, but we're letting you experience humanities, as Penn State has been doing for decades, global perspective, empathy. How can thought leaders in medical education help impact political science education so that they are not just learning that data is important, but they are, like you're experiencing, global perspective is important. Those entering political science are experiencing that data is important. So any thoughts on that?
That's a great comment. No, I mean, it didn't even occur to me. I mean, that's kind of a brilliant insight because we don't ever allow people to experience the other side in politics. We never exchange.
I'll add, that is a really good insight. I'll affirm that. And a number of programs are starting to develop, whether it's at medical school or more likely residency so far, but programs related to policy for their residents. So how to write policy or engage with legislature, those sorts of things are starting to develop. There's a group that's called Beyond Flexner Alliance for medical education. If you're interested, it's a great group that's interested in these sorts of topics. And that really came up this past year around how to kind of bring medicine together with other partners, whether it's legal or people in the legislature, governor's office, and so forth. Yes, sir.
Sorry, I just wanted to add one more comment to the political sphere comment over here, but I'm actually one of the curriculum chairs for our class, and I can confirm some of these conversations about politics or business of healthcare and how they affect us. We are talking about those things. Even now, we have a health system science class where we meet once a week and kind of talk about like these bigger concepts that will affect our care as providers in the future. So as a student, I think it is really important that we're aware of all of these different people and different professions that do affect us. So I guess I can't speak for the political science students and their curriculum, but I think it's been really interesting from someone who only I did bio and public health in college, and I don't really know much about, political science or the economics of it, but having those public health implications here in medical school have been a really great segue into tying in some of those concepts. And my public health degree in undergrad did talk about policy. So it's been cool to kind of see that pulled into our medical education where I think it is going to affect us the most.
I basically have a comment for Dr. Birx. Never dreamt that I would be in the same room with you. But as we all watched you stand within the jaws of adversity and insanity, you held your ground and you made the medical community, and particularly the Hershey medical community, very proud. And I want to thank you.
Thank you. Thank you. You know, this is what happens when you come out of the military. I think all of these things happen for a reason. Hershey, I got into several Pennsylvania medical schools, but at that time, Hershey was less, well, $3,000 a year, $1,500 a semester. So I could afford it and I didn't want to be in the military. But I didn't understand that my husband, by taking the scholarship, meant he was in the military. So in the end, I had to join the military when I finished medical school in order to be with him during internship and residency. And I think that training you hold no matter what. You can't ever like say, wow, this is really making me look bad and feel bad, so now I'm going to quit. That just, you know, in the military, that would be so unacceptable. So I think these things happen in your life for a reason. Really saying this for the panel, none of my life was really planned. And I kind of floated from, oh my gosh, I have to join the military to be able to be with my husband, so I'm going to join the military, which most people would say that was a big life decision, but it was just one of those things on my road of life. And I try to stay in the moment rather than planning, I'm going to do this, to strategically have 3 chess moves ahead. But I think that kind of training really helped me be able to, what you said, stand ground. I would say that most people in the White House that didn't like me would have used other words to describe me, but I appreciated that it wasn't one of those words. And they did plan a lot of stories in the New York Times trying to get me to quit, but I was like, obviously you don't know me because I'm not quitting. So I finally said that to him in September, you can keep doing this and I'm sure you will, but I'm not quitting. So you can say really horrible things, but I'm not leaving. Didn't stop them.
So I just wanted to respond and build on your comment about healthcare in rural America. You know, my family's I'm first generation to not grow up on a farm in Lancaster County after my family being farmers for 300 years. So I have a deep appreciation for the complex politics of, you know, rural United States. And I think the challenge I come into as an early career physician, the cost of education is so high. We're not increasing funding for medical education. We're not increasing funding for residency. And then having gone through residency now with 4 ACGM emergencies, you know, a third of my internal medicine residency was critical care. You know, pulm elective turned into ECMO management. Everything was critical care. And I think a lot of us that are early career are looking and saying, we can't afford to go and do primary care in rural America. And we're not sure whether we can even sustain this career that we're into with the way we've been worked in the pandemic. And I think that, you know, I've sat with a lot of my colleagues and close friends in mental and emotional crises on a regular basis. And I guess I'm kind of wondering, there are those of us in healthcare that want to step into this gap in these politics. And, you know, I have an MPH in healthcare management, but we're wondering like who in the country has our back to help us do that.
You know, we had great discussions yesterday with your medical students and faculty here. So they're as awesome as when I was here. And you always worry about that, you know, when it matures. I think I was like the 9th graduating class. I mean, you worry, do you lose that kind of grit and, you know, wanting to do this kind of right thing? It's going to require legislative fixes. I think a simple legislative fix for some of this is if we require NIH and all of the HHS, what they call optives, SAMHSA, who works on mental health and drug addiction, CDC, HRSA, which has a lot of clinics in rural areas. If we require 20% of their funds for research and implementation go into rural areas, then we create a funding stream. 20% of Americans live in rural areas. And so I don't think it's much to ask that our research and our interventional dollars, our federal programming dollars should reflect that, because you're absolutely right. There is no sustainable way to exist in rural America because hospitals are closing on a regular basis. They're, you know, I think everybody believed the hub and spoke model would work. But when the spokes are full, there's no place. I mean, when the hub is full, there's no place for the spokes to go. And a lot of people died without ventilators and ECMO. It's never talked about, but you know what happened out in rural community hospitals because they couldn't move them. There was no place. I mean, I'm sure you heard the stories of family members dialing for ECMO. I mean, This is the United States. So you're absolutely right. I will also take your, but I think you know what you all can do. We talked about this, about what Parkland did. I mean, Parkland finally, I think, was the breakthrough because young people stayed on message and just kept fighting. Locally, nationally, they just kept this gun violence thing going. It's not, I mean, no one got as far as we wanted. But imagine a coalition of medical students keeping that going and going to the state and national legislatures and saying, this is why this is happening. They understand, I think, for the first time, student debt. So they think of that, though, as college student debt. So I think you make such a critical point.
One last question.
I want to thank Dr. Fredrick, the student panel, and Dr. Birx for a tremendous lecture today for us. I have a background in public health as well as my degree from Penn State Hershey that I'm thankful for. I want to ask a question about in the global health. How many have gone through? What numbers so far?
Oh, boy.
More or less.
Quick math. I'm guessing 150 or 200.
Okay.
Something like
Do you
that.
have a sense of what they've done afterwards, like into their careers and how it's?
We're actually about to embark on that. We're at the point where we've graduated enough, where I think we have a sample size that's decent, and they've gotten out of residency and they're in practice. So
Okay.
we haven't done that. It's only anecdotal. It's
Right.
me running into them and similar conferences.
One thing that international health, international work helped me in my career thus far was the time I spent in Ecuador as an undergrad and at Pitt, and through 7 weeks of, first of all, understanding, as you did, all of you did, where you were going, and then coming on site and doing projects. It impacted me lifelong, which it will to you, to all of you young people here. I know Dr. Birx will say the same, and Dr. Fredrick. What I want to say is we have so many sub-communities within our community. Know your population. Try to go in as you're, go into the homes. I went to the Indian Health Service, and I would ask the children, I'm a pediatrician by training, but I ended up in general medicine as well. And I would say, what do you want to be when you grow up? And they would not answer me. They didn't have an idea. And I was so saddened. And I went out and saw them lying there and looking at flies on the wall to flies. This is what they were doing for play. So I started some public health interventions in these communities because you actually knew what was happening. When we write a prescription for amoxicillin and they don't have refrigeration for the liquid, it doesn't help. And you've learned this already. So you're going to bring this into your careers. And I give you a lot of thanks for getting this global health initiative off the ground.
Thank you. Thank you for your comments too. Wonderful.
Well, thank you all so much for coming. We are delighted. I am inspired by what our future is going to hold. This table of bright young students is amazing. Thank you, Dr. Fredrick, for all the work that you're doing to educate them and give us opportunities outside of the walls in Hershey. We are going to invite you to join us for lunch now outside at the tent. So I invite you to head out, stick around. Maybe the students will mix and mingle with us outside. So thank you so much for joining us.